Hello, and welcome to the E-Converge podcast. This is the third episode on discussion of the economics of healthcare, the public healthcare system versus the private healthcare system. In the last episode, we've talked about the private healthcare system. We've used the US as our closest example to a fully privatized healthcare system in the developed country. And today, we would be talking about the public healthcare system. We would using the UK as our main example. We would also talk about China's healthcare system as a sort of supplement to the UK system. The reason is kind of twofold. On one side, both systems are adopting what we call the universal healthcare. If you recall, we've mentioned it in the first episode, that the universal healthcare is a healthcare system in which all residents of a particular country or region are assured of an access to healthcare. This is very much centered around, let me write it here, the idea of equality. And indeed, it is the most common healthcare system model that you can see around the world. For another reason why we've chosen the UK and China as our example for the public healthcare system is that both countries are similar in terms of they're both having an aging population, therefore meaning a growing in as demand for healthcare. Also, they have a decrease in or lower in fertility rate over the past few decades. I think I might write it here. They both have aging population and fertility rate. Fertility rate decreasing. I know you might say that in those terms, in terms of a behavior of the economy, that the UK is not very similar to China, but that's the point that I would like to make. That I'm not choosing them because they are the most similar to each other, but rather they represent two different kinds of public healthcare system. The NHS, or the UK healthcare system, is chosen because it is a very nice representative of the Western or the European model of the universal healthcare coverage. It's adopted by the original model, the Bismarck model, named by the German Chancellor before World War I, that started off as a form of injury pay to workers that gradually developed into today's universal healthcare that we see in most countries. China, on the other hand, has a very distinct historical development of its healthcare system. And in terms of population densities and other economic factors, the two countries are very different. So the whole purpose is to give us kind of like two different versions of public healthcare system in real life. And that is here that I would very much like to note that the purpose here is not to compare the two systems. I'm not in any way comparing the UK and China system in terms of talking about which is more advanced or which is more superior, but rather they are so different in nature. There isn't real much significance in international comparison in that way. Also, I'm talking about China as a supplement because although it is a public healthcare system, it is relatively unique in regards to the sheer size of Chinese population, the geographical location, and some of the historical reasons. So I think it's very good that we can look at it as maybe some sort of alternative version of public healthcare. Also, there is insufficient amount of data that I am able to research and find on the internet for me to make any real argument well supported by data and evidence to compare it or using it as the main representative of a public healthcare system, which is why, as I've said in the beginning, we are using the UK as our main contrast to the private healthcare system. So hopefully by the end, we would get a very clear idea of how the public healthcare system looks like and what are some inefficiency arise due to its model of allocation of resources. And we would be able to having a very evaluative idea between the public and the private healthcare system. It would be interesting. So let's do this. First, I would like to start with talking about the UK healthcare system. I know we've introduced the UK healthcare system very, very briefly in the first episode, but I like to refresh your memory a little bit. So this is a general structure of the UK healthcare system. All you really need to know here is that on the top we have a DHSC, Department of Health and Social Care, and down we have the NHS, the National Healthcare System, and we have NHS Trust on a regional level, which is really just an organizational unit within the NHS that covers a regional area, or it covers for like a special purpose. The UK healthcare system, as I've said in the beginning, it's a very good representative of the European or the West model of universal healthcare system. Many countries have very similar models. This is the health expenditure as a percentage of total share. This is one from the OECD report. You can see that the United Kingdom is here, about 79%. Let's just say roughly 80% of the health expenditure has a public source. And in terms of UK, it's 100% funded by taxation, the general tax. Which means that it is unconditional. UK citizen is able to access healthcare provided by the NHS, and it's largely free at the point of use. It is not free for certain special areas such as dental, eye check, cosmetic, but for most services, it's largely free. And it has, which is one of the main merits in addition to free, it has 100% coverage. In addition to financing the healthcare, the UK model is also what we call the Nordic model. Which means it's not only a single payer system. We've mentioned this in the discussion of the US. It's not only the UK or the NHS is not only paying for the healthcare service, but is also the largest provider of healthcare in the UK. And here is very general structure on how healthcare services are structured. You have the primary care, and here you have the specialist care, which we also refer to more commonly as a secondary care. So primary care include more acute illness, where you see a GP, a general physician, or general practice doctors. You can see here for some certain diagnostics or for treatments, or for them to refer you if you have a more serious sickness or injury to see a specialist care. This also includes some of the emergency cares. So this is the primary care. And in Western countries, specialist cares are usually in a large hospital where you see specialists for more serious conditions, such as if you require surgery or other therapies that requires a specialist attention. I would very much like you to keep this in mind, because later on when we talk about the China healthcare system, you will realize how the healthcare service is conducted in China is very different to what the West sees as this routine of healthcare service. So here on the right hand side, I also have a small screenshot of news talking about the Britain's beloved healthcare system falling apart. And mostly it's due to waiting time. I have, a few sets of data that can give you an overview of how severe the problem is right now. This is the share of people waiting 1 month or more for a specialist appointment. United Kingdom is here. Despite it not being the most severe cases of all the OECD country, is still among the top rank. And you can see a very clear increasing trend over from the last 6 years. This is again waiting time for common surgery. The United Kingdom is here, which is, I guess, 60 to 70 days that one needs to wait for a common surgery. Waiting time for emergency department, again, you can see a very, very clear increasing trend over the past decade. And for the United Kingdom, waiting list here has been, accounted for over 90%. 90% would be here. It's over somewhere above here, over 90% as the reason for that the healthcare need is unmet. So I guess you want to ask why. Why is the problem occurring? This is a very, very, very complex question, and it has a lot to do with how the resources is allocated that is leading to this problem of shortage. We have a few more sets of data here that give you an overview of how different kinds of resources in the medical system is in shortage. For the UK cases, the number of hospital beds has halved over the past 30 years. This is partly due to the NHS digital bed policy, but it is not working properly as it should, therefore creating a lot of the strains on hospital admission. The MRI machine, you wouldn't find UK in this graph. The UK is about 8.6, which is probably somewhere down here. In fact, the number of MRI machine UK has per million population is one of the lowest in the OECD country. Similar for CT machine, the UK only has 10 per million population, and the US has 42 per million population. And the US is not the highest in the world. Even among all those, I guess you can say, owned resources, a lot of it is out of date and requires an update or upgrade. This is difficult to analyze by data, but to give you an idea is that it's a little bit interesting that up until the 2018, the NHS still owns 8,000 fax machine across the country. So there's a lot of out-of-date technology and equipment in use. This is again on the hospital bed. It's one of the lowest in the OECD country. United Kingdom is here. And the UK has a problem of staff shortage. Job vacancy is this much up until 2023, and there is a decline in the NHS nurses' average basic earning in real terms over the past from 2011 to 2022. So I guess the shortage of resources can be divided into two parts. We have a staff shortage, and we have an even more significant problem on capital shortage, which includes the infrastructure, the equipment, even the hospital buildings itself that are in use to provide healthcare services. And you might ask also, why is this problem occurring? Is it because that the NHS is lacking in fund? Well, it's not as straightforward. In fact, this is the past from 1955 all the way to 2020's NHS England spending. It's an increasing in rate. There is no negative on the scale. So there is a decline in the rate that the spending is increasing. However, in real terms, the trend is going up. NHS spending. So how come that a medical system with an increasingly spending had facing such a severe situation of resource shortage? It's really difficult to answer such a complex question in a very simple and straightforward answer. There are indeed various potential causes for it. For example, aging population. Aging population, which, as I said in the beginning, would potentially increase the medical need as people age, and it would put a strain on the medical system, potentially leading to a situation of resource shortage. And there are the 2008 financial crisis, which, as you can see on the diagram here, it dramatically decreased the rate of NHS increasing its spending. And of course, there is also a level of corruption and bureaucracy, just like in any other system, but this is relatively difficult to analyze and demonstrate by data and chart. So what I really want to talk about in this video is to focus on the problem of capital shortage. Capital shortage, which includes the problem of hospitals, the lack of hospital beds, as the example we've given earlier, and the lack of, for example, MRI and CT machines and other medical equipment. This is relatively easier to be measured and demonstrated by data, and therefore easier for us to analyze. The current NHS capital shortage situation is mainly caused, in a very brief summary, by a history of a neglect in capital investment, followed by a not very successful policy in cooperation with the private sectors. But before I start to analyze more in detail of the problem, I would like to make a note that the rest of the data I used in the following part talking about the UK, you might see the graph here that the sources author analyze. So they're from an independent think tank called Institute of Public Privacy Research. They were all taken from the report, which does not really have a clear reference under here, if you can see. I just like to make a note of that. If you like to read the report yourself, it's a really nice report. I will also attach the reference in the description below. Okay, so there are two figures on the past decades of NHS general capital investment. UK has a relatively low capital spending if you can look at the trend from 1975 all the way to 2017. Also here, this is the red one is the UK, which is here. It is significantly lower, in fact, one of the lowest capital investments compared to all the other OECD countries. You might notice a little abnormality in the graph that is from 2005 to roughly 2009. In this period, the NHS capital spending had actually peaked and went beyond the OECD average. This is a period where it's later referred to as the PFI legacy. I will write it here. PFI legacy, which later on proven to be a strain on the system, but we will talk more in detail about that later. I just want to give you a brief idea about the problem of capital investment within the NHS. So the capital spending in NHS works like this. On top of NHS, there is the DHSC, Department of Health and Social Care, which oversees the capital investment. For NHS would be here. They have something called the Capital Department Expenditure Limit, which is well, basically talking about infrastructure, land, machines, and so on. So the NHS bumped into a problem during the 2008 financial crisis, where the lack of fund causing the NHS to do what is called capital to revenue transfer. Revenue transfer. So, well, I think it's better to have the link here. This is 2008 financial crisis. Okay. And, well, probably another reason is also the lack of substantial funding. I'll just write lack of funding. Because as we've talked earlier, that is primarily, actually, in its real data, 100% founded by general tax. So this caused a lot of the capital investment. As you can see in this diagram, there is an increasing in capital budget not spent on capital, which means it is spent from day-to-day care, day-to-day maintenance of the system, for example, paying staff salaries, paying probably maintenance on certain equipment, paying drugs, paying all sorts of day-to-day cost, rather than putting into capital investment, buying machines, building infrastructures, stuff like that. So the budget spend is relatively constant. Well, there is a small decrease for between 2014 and 2016, but it's relatively, well, I guess you can say constant, but the part spent not on capital is increasing, and this is the situation. Well, I can see it here. It's the situation of capital to revenue transfer. And the solution came, as we've talked about early on, by the PFI legacy. So you might ask, what is PFI? This is 2005 to 2009. Not only it saved the situation, but it also created a time where it's very apparent that the UK's spending on capital investment actually exceed the OECD average, which is, well, from here to there. So what is it? It's called private financial initiative. It's basically a form of PPP, which is public-private partnership. I'll just write PPP here. The public-private partnership is a form of long-term contract between the private sector and the public sector for providing certain public, for the private sector to provide certain public assets or services. This could take in many forms. This could take in form like private sector directly involved in constructing, delivering certain services, or it also can take in form in the way that the private sector is providing the finance for delivering certain services. So it's relatively difficult to define public-private sectors in real day-to-day terms. And the central idea, let me find a new color for this. So the central idea for private-public partnership is about risk sharing. That public and private sector are each good at bearing different kinds of risk. For example, the private sectors, private firms, are better at constructing, maintaining the cost, and bearing the risk of different projects. I'll just write cost and, for example, construction risk. It would be, I guess, more relevant to the case we're talking about. And the public sector is better at bearing certain risk associated to policy. For example, it is better at bearing maybe change in interest rate, although that is a very large policy. Also, another benefit for the public-private partnership is finance. The idea is that the involvement of private sector in such, usually the government project is very large and involve a huge amount of investment and financing. So the idea is that the private firms are able to provide more finance into the project. And also it is generally more flexible. Since the private sectors are involved, there are maybe a handful of different funding options for the project itself that makes it very flexible to adjustment for market changes and policy changes. The overall private-public partnership is just about increasing efficiency. For the construction and also sometimes later on the maintenance of large public projects. As I've said earlier, that the PFI, the private financial initiative, is just a form of public-private partnership. What it really does is that the NHS, let's say that the NHS want to build a hospital. So it put out a tender for the private firms to compete to get the right to build the project. So, but they're not just one firms, they're actually consortiums, which is basically just a group of private firms. And after they get the project, they are now called special purchase vehicles. Special purchase that's a misspelling. Vehicles. SPV in short. That's just a fancy name to call the group of firms that are actually in control of the project and is responsible for constructing and usually later on maintenance of the whole project. And what it does really is that now it starts to construct. But the important thing to note here is that the special purchase vehicle, the SPV, are not directly, or they don't usually have enough investments for the entire project, because the NHS would only start to pay for the project once the construction is completely finished. So it usually would get the investment, well actually I write it in green here would be better. It would usually get the funding from a bank in the form of senior bonds. So this is a very common way of getting the fund for any kind of investment. So once the construction is finished, let's say the construction is now finished, the NHS would give basically an unitary payment. Let me write it here. Unitary payment to the special purchase vehicles in the form of basically annual payment, which usually has been decided at the beginning when the contract is signed. So some of this payment would go into the special SPV themselves to basically cover the profit and the cost of all the construction, and another part would go back to the investors in the form of interest. So this is basically how this PFI works. And the idea behind this is, just as I've said before earlier, with the public-private partnership, it's about risk sharing, and it's also about especially for the NHS cases, injecting fresh capitals from the private sector into the NHS, which is right now, during the financial crisis, has suffered basically a shortage of fund for its project. This whole idea about the private financial initiative is very well theoretically that the NHS is able to gain from the extra injection of investments from the private sector. Also, the private sector is offered an opportunity to make certain profit. But if we move around here, there is the IPPR report on the annual payment the NHS has to pay to its PFI contractors. Well, we're currently here, 2024, and the annual payment is already roughly 2,500. This is in million pounds. And such payment would continue to increase until 2030. And in fact, the accumulated estimated amount that the NHS is going to pay overall to the PFI project would be £80 billion. And so much is charged actually for capital assets that is only worth £30 billion. And we've roughly had this PFI project for about 20 years, and guess how many we have outstanding? 55 billion. So it's not hard to see that the high cost so far is a drain on the NHS funding, which is already fundings in any medical system would be in shortage, but this is a huge drain on the resource itself. Here is another table for the amount each NHS trust has to pay to its PFI contract. Note this is not for their current services. Most are paid for their past service or for the past construction project that had already completed. Remember that the NHS only starts to pay the PFI firms once their construction is completely finished. And the largest one here would pay 16% of its net income just for you can see the past historical construction. Maybe a proportion of it would go for the current maintenance, but most of it would go to the past project. So you can see this essentially as a form of loan, although this is it's not a perfect analogy, but it's a bit like a form of loan, where the NHS is essentially borrowing money from the SPV or the private sector, who is in charge of building and maintaining the project that the NHS are making use of their results while annually paying back an amount with certain amount of interest, of course. So the benefit of it is it did indeed bring about the legacy in between 2005 and 2009, where there is an increasing amount of capital spending, which presumably would go to the benefit of the system itself. But in long term, it leads to a very high cost, and the cost is still piling up. We're not just talking about maybe one or two PFI project. We're talking about a nationwide amount of project piling up into a huge drain of resources on the NHS itself, which feed back into the initial problem of lacking for fund and initial problem of diverting capital investments or the capital investment budget into just paying the previously constructed PFI project annual payment they own. And it's not only that the construction costs are very high. I have here another comparison of fee paid for services and maintenance compared between PFI and a freeholder. According to the IPPR report, that the PFI contractor would charge roughly about 15% more for the same service. And during the coalition government, Prime Minister David Cameron had quoted one hospital trust was charged about more than £300 by its PFI contractors just to change in a light bulb. So if I zoom in, this is maybe a clearer pictures on how this vicious cycle keep going and keep draining the resources and leading to the situation that we have today. And in 2018, that the government had officially banned more PFI project to be initiated. But it does not cancel out the previously made contracts and the payments, which has an extremely long-term effect. All of them would have to be paid on all the way until, 2050. So why is this happening? It seemed like that the entire private financial initiative was designed to solve the problem of lack of fund and to at some stage introduce competition and introduce better management to bring down the cost, to increase efficiency. But rather it is creating a situation of not just inefficiency, but a huge shortage, a huge drain of resources. Well, personally, I think there are three main reasons. One, anyone would presumably argue that there is a level of corruption and bureaucracy in the system. Well, it might be true, but there is no reliable source of data that can tell us how severe the problem is, how much it is really accounted for the current situation. So we will not, or at least I personally would not use it as the main cause, the main explanation. The second reason, or I think is a lot more important reason, is the funding source. By creating this PFI, the NHS is transferring the risk largely to the SPV, at least the whole risk during the project in concern of construction and management. And the SPV, it's not the sole investor of the project. It might have, or some SPV might have contributed a large sum into the construction project, but on a bigger scale, its investment also comes from, basically society. It's in form of banks giving out senior bonds. So as an investor, considering that the SPV is bearing the full risk throughout the project, that it will not receive any additional payment from the NHS until the project is ended, the high risk of the project in itself would presumably give any investors a right to demand a higher return. So part of the risk is transferred to the SPV and part of the risk is transferred to the investors. And that in the end would all translated back. This would in the end translate back into a higher amount of payment or a higher cost that the SPV demand for the NHS in its unitary payment amount. And this private source of fundings increase the cost of borrowing for the SPV and increases the cost that eventually incurred for the NHS. And in fact, one of the proposal on modification of current PFI scheme is to replace the PFI by a public source of fundings backed by government or backed by central bank in one way or another, to basically bring down the cost of borrowing for the SPV in order to bring down the cost of entire construction project or, future project we're talking about. And I think another very important reason is also about monopoly. Well, I'm not really talking about monopoly in terms of monopolizing the industry, or not in, I guess, a more conventional form. But I'm talking here specifically about the high maintenance cost we talked about in this part. The PFI contract is not a, short-term contract in any sense. Usually these contracts accounts for 30 to 50 years, usually. So despite there is an initial competition from the consortiums to compete bidding for the project, that in the end, once the contract is signed, the SPV is the only provider in the whole system, at least for a particular NHS trust. And that level of monopoly would, due to the nature of PFI, the long-term contract, allow the SPV to potentially charge higher price. Maybe not for the construction program, because that was predetermined in the contract, but for some of the later maintenance cost. If you recall back, we've talked about here that compared to short-term freeholders, the PFI would charge 15% more for the same amount of service they bring. So basically, that's all about the current situation or the problem of capital shortage in the UK healthcare system so far. To wrap up for the UK healthcare system, I guess we don't have enough time to talk about the China system, so I would do that in the next episode. With the UK example, we've seen a largely public healthcare system, which is a very nice contract with the US system, who is largely private, that we talked about in the last episode. We see that the government has a very different role in the healthcare system, where it is basically the most influential and most important participator in the whole system, that has a top-down influence that every decision it makes, for example, in this case, cooperation with the private sector, has an incredible amount of influence towards the entire medical system and all the other participators in it. It's very different from the US system we've talked about last time, where despite the influence of government, it is only one of the important participators within the system, and it has a relatively or comparatively limited amount of influence in how goods and services are provided, what price they are charged in the system. The benefit of such a public system, as we've talked about at the beginning, is that it allows that, to a large extent, that the system is behaving in the collective interests of all the population. It ensures a certain amount of equality within the system, and it provided healthcare that is affordable and accessible for all. But on the downside is that it is not a very efficient provider in terms of providing the goods and services in the way that the NHS is providing so far. And some of the not very, I guess you can say, decision it makes, especially like the PFI situation we've talked about right now, has a very long-term influence over probably the next few decades, at least 2 decades of the UK healthcare. And we also see a very nice example of problem occurring when the public sector is trying to transfer some of the risk it's bearing during basically the provision of goods and services to the private sector. So in the next episode, we will be talking about the China system, which is again also an example of public healthcare system, but, well, I guess you can say in a vastly different way, how it has some of its unique merits as well as unique problems. We will be able to see the difference between that particular system to the system we've talked about today and to the US system, the private system we've talked about in the last episode. So that's enough for today. I hope you really enjoyed the discussion on the UK healthcare system, and I'll see you in the next episode.